Hello everyone, my name's Carrie and I will be doing my presentation today on suicidality and homicidality. You'll have to excuse my presentation. I had to get a little bit creative because I could not get my PowerPoint to export, so I had to go another route, but I think it'll all work out. All right, well, today we're going to be discussing suicidality and homicidality, two of the most serious crises encountered in mental health counseling. Mental health professionals have ethical, legal, and clinical responsibilities to recognize risk factors, assess danger, intervene appropriately, and connect clients with life-saving resources. And throughout this presentation, we're going to be reviewing evidence-based suicide prevention models, crisis intervention strategies, trauma-informed care principles, methods for assessment of trauma related to suicidal or homicidal thoughts. We'll look at mandated reporting requirements for abuse and neglect, and then trauma-focused treatment approaches. We will also examine community resources available nationally and specifically within Omaha, Nebraska, where I'm from. Suicide remains a significant public health issue in the United States. According to the Centers for Disease Control and Prevention, suicide is among the leading causes of death, affecting individuals across all age groups. Risk increases substantially among individuals experiencing depression, PTSD, substance use disorders, chronic illness, social isolation, and those that have had a previous suicide attempt. And although homicide occurs less frequently than suicide, homicidal ideation also requires immediate assessment. There's a lot of risk factors for homicidality, which include previous violent behavior, psychosis accompanied by those command hallucinations, severe personality disorders. We've got substance uses in there, impulsivity, and easy access to firearms or other lethal weapons. Understanding these statistics reminds us why early identification and intervention are so important. Several evidence-based models guide suicide prevention efforts. The Zero Suicide Model is a systems-based approach used by healthcare organizations. It emphasizes leadership commitment, workforce education, routine screening, evidence-based treatment, and safe transitions between levels of care, as well as quality improvement. The QPR model stands for Question, Persuade, and Refer. It teaches community members and professionals to recognize warning signs, ask directly about suicide, persuade individuals to seek help, and then also to refer them to appropriate services for follow-up. A couple more: ASSIST, which is Applied Suicide Intervention Skills Training. It's an internationally recognized training program that prepares individuals to intervene effectively with someone experiencing suicidal thoughts. And then finally, safety planning intervention. It's become the preferred clinical intervention over no suicide contracts. Safety planning is collaborative, it's very individualized, and it's supported by strong research evidence. Effective suicide prevention begins with comprehensive assessment. Warning signs include talking about wanting to die, expressing hopelessness, maybe you're feeling trapped or withdrawing from loved ones. Your substance use might be increasing. You might give away your possessions, take part in reckless behavior, and then there might be some sudden mood changes after depression. Some of the risk factors include previous suicide attempts, psychiatric disorders, a trauma history, chronic pain, if there's a family history of suicide, financial stressors, and then firearm access. Protective factors help reduce suicide risk, and these include supportive relationships and effective coping skills, spiritual or religious beliefs, engagement in the treatment process, having future goals, and just having reasons for living. And as counselors, we evaluate all three categories before determining the level of intervention needed. I wanted to take just a quick little break and look at some of the myths surrounding both suicidality and homicidality that can contribute to the stigma and delay appropriate intervention. One common misconception is that talking about suicide or harming others is simply attention seeking, or that people who talk about it will never act. But in reality, any expression of suicidal or violent thoughts should be taken seriously and evaluated. Another myth is that someone asking directly about these thoughts will encourage them. Research shows that asking in a calm, non-judgmental way does not increase risk, and it can actually help someone feel supported. And while mental illness is an important risk factor, suicidal and homicidal thoughts may also occur during periods of overwhelming stress, during trauma or grief, substance use, or major life changes. So it's important to remember that having suicidal or homicidal thoughts does not mean someone will act on them. Risk is determined by multiple factors, including intent, planning, previous behavior, and those protective supports. And finally, recovery is possible with appropriate assessment, treatment, and support. Many people recover and no longer experience persistent suicidal or homicidal thoughts. So it's just I thought it was interesting to look at some of the myths and then compare them with actual facts. Avoid making assumptions based on myths. Taking concerns seriously, asking direct questions, and connecting individuals with appropriate support can help prevent harm. Once suicide risk has been identified, counselors should respond immediately and systematically. If a client is at imminent risk, so immediate risk, they should never be left alone. A comprehensive suicide assessment should be completed, including intent, plan, means, and protective factors. Whenever possible, lethal means should be removed or secured. Research consistently demonstrates that reducing access to firearms and medications decreases suicide deaths. Developing a collaborative safety plan is an essential intervention. Hospitalization should be considered if safety cannot be maintained in the community. And then finally, follow-up care after hospitalization is critical because suicide risk remains elevated during transition back into the community. Crisis intervention aims to restore safety and stabilize individuals during emotional emergencies. Roberts' 7-stage crisis intervention model provides a structured approach by first assessing safety, establishing rapport, identifying problems. It also explores emotions, generates alternatives, and develops an action plan while also then providing follow-up at the end. Psychological first aid is commonly used following disasters, mass violence, or community trauma. It really focuses on promoting safety and reducing distress, really increasing the connectedness between community members, strengthening self-efficacy, and then fostering that hope that they need during those difficult times. Both of these models emphasize stabilization before long-term therapy begins. Trauma-informed care recognizes that many individuals experiencing suicidal or homicidal thoughts have survived significant trauma. SAMHSA identifies 6 core principles. Safety means creating both physical and emotional security. Trustworthiness involves transparency and consistency. Peer support encourages healing through shared experiences. Collaboration emphasizes partnership between counselor and client. And then that empowerment really focuses on client strengths rather than deficits. And finally, cultural humility recognizes the impact of culture, identity, and historical trauma on mental health. And trauma-informed care, it really shifts the clinical question from what's wrong with you to what happened to you. Mental health crises require collaboration across healthcare systems and communities. National resources include the 988 Suicide and Crisis Lifeline, mobile crisis teams, community mental health centers, NAMI, the American Foundation for Suicide Prevention, and others that are listed there. Community-based care really allows for individuals to receive treatment in less restrictive environments while maintaining family and social supports. And following disasters, counselors often provide that psychological first aid before transitioning individuals into longer-term treatment. Looking specifically at Omaha, it has several valuable crisis resources. There's the Nebraska 988 Suicide and Crisis Lifeline, provides free confidential support 24 hours a day by phone or by text. The University of Nebraska in Omaha Counseling and Psychological Services offers crisis counseling, suicide prevention education, and emergency consultation for students. One I discovered when doing research here was the Kim Foundation, and it provides mental health education, community outreach, and resource navigation throughout Nebraska. One of our local agencies here is Community Alliance. They offer behavioral health services, crisis stabilization, psychiatric rehabilitation, and then case management services as well. And then finally, the Nebraska chapter of the American Foundation for Suicide Prevention provides educational programs, support groups, and then those community awareness events that we see. And these organizations all work together to improve access to mental health care across the region. Trauma assessment is an essential part of suicide and violence risk evaluations. Counselors should ask about childhood abuse. They should ask about neglect, domestic violence, sexual assault, community violence, maybe medical trauma or national disasters. Important clinical questions include asking whether suicidal thoughts began after a traumatic event or whether certain memories trigger suicidal or homicidal thoughts. There's also validated assessment tools that you would use as well during assessment. They include the Adverse Childhood Experiences Questionnaire, which is the ACEs, the PTSD checklist for DSM-5, and the Columbia Suicide Severity Rating Scale. I'm really familiar with that one, the CSSRS. We use that often in the agency that I work with. And these assessments really do help clinicians understand the relationship between trauma and current safety concerns. They really do tell us a lot. When it comes to assessing homicidal risk, it follows many of the same principles as suicide assessments, but includes some additional considerations. Like counselors need to assess whether there's a specific target, an intent to harm, is there an organized plan or access to weapons? Has this individual been involved in previous violent behavior, or is he impulsive, prone to substance use? We want to look at all those, but then we also want to look at protective factors as well and build on those strengths. Clinicians also consider legal responsibilities, including the duty to warn and duty to protect when a credible threat towards an identifiable person exists. And always remember that documentation and consultation with supervisors are essential during all of these assessments that are going on. This would be the part of the presentation where we would have a small group activity. We would break into small groups, talk about a case scenario where we have Jordan here, a 24-year-old graduate student, schedules an emergency counseling appointment after recently ending a long-term relationship. During the session, Jordan states, "I don't think anyone would really miss me if I were gone. I'm exhausted from pretending everything is okay." So if we go through this in small groups, we would look at all of these things that he's reporting, right? A history of childhood emotional neglect, missing work and classes, feeling hopeless. We'd be noting all these things. And then we'd ask some of these questions, what are the warning signs that are present? What additional assessment or questions do we need to ask? Asking, are you suicidal, is not enough. We'd want to look at maybe these are some of the warning signs and risk factors that we would have identified during our small group activity, working together, seeing some of these warning signs, noting the risk factors. And then we'd gather for some assessment questions to end out this small little activity. So some immediate interventions that were noted was to complete a comprehensive suicide risk assessment. We'd want to develop a collaborative safety plan for Jordan, restrict access to the firearm, identify support people, determine whether hospitalization is needed at the time, and arrange for very close follow-up. And I think had we had the opportunity to get into small groups and do this activity, I think we would all be coming to the same conclusions for Jordan. Mental health professionals are mandated reporters in most states. So when it comes to reporting abuse and neglect, some of the reportable concerns might include suspected child abuse or elder abuse, abuse of vulnerable adults, neglect and abandonment, and even exploitation now is included in there. Documentation should always remain objective and include direct client statements, behavioral observations, dates and times, maybe any injuries that were observed, and any actions that you took. And counselors should also explain the limits of confidentiality early in treatment with your individuals, so clients understand that safety concerns might require reporting. Looking at trauma modalities for suicidal and homicidal clients, there are several evidence-based therapies effectively addressing trauma while also reducing suicide risk. DBT, which is dialectical behavioral therapy, has extensive research demonstrating reductions in suicidal behaviors through skills training. And that skills training takes place in 4 different areas. That's in mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. CBT, which is cognitive behavioral therapy for suicide prevention, focuses on identifying thinking patterns that are associated with the suicidal behaviors. And then cognitive processing therapy really helps individuals challenge trauma-related beliefs that are contributing to their depression and their hopelessness. There's also trauma-focused cognitive behavioral therapy. It's especially effective for children and adolescents, a little bit younger. EMDR, which is eye movement desensitization and reprocessing. It can successfully treat PTSD after clients initially achieve that emotional stabilization. And then Seeking Safety is a group. Usually it's run as a group. It's particularly helpful for individuals experiencing both trauma and substance use disorders. I know at the agency I currently work at, we have a Seeking Safety group that's specifically just for women dealing with domestic violence and trauma as well as substance use. So I'm quite familiar with the effectiveness of Seeking Safety. Safety planning is considered one of the most effective interventions for individuals experiencing suicidal thoughts. The plan is created collaboratively and includes 7 different components. So you're going to want to recognize personal warning signs, use internal coping strategies, identifying people and places that might provide distraction, listing of family members or friends who can offer support, identify those professional resources, calling emergency services or 988 during a crisis, and reducing access to lethal means. And unlike older no suicide contracts, safety plans actually provide concrete behavioral steps that client can follow during crisis. When you're in that high state of emotion, it helps to have a list or a safety plan, saying I'm going to do this and I'm going to do this, and it'll walk them through that crisis. When it comes to ethical and legal responsibilities, counselors have significant ones when working with suicidal or homicidal clients. The ACA Code of Ethics emphasizes benevolence, doing no harm, confidentiality, informed consent, documentation, competence, and consultation. Clinicians should routinely assess suicide risk, document assessments thoroughly, consult supervisors when needed. You want to understand all the state laws regarding duty to warn and mandatory reporting, and you're really prioritizing client and public safety. Professional judgment should always be guided by ethical standards and current best practices. To conclude, suicidality and homicidality require immediate evidence-based interventions. Trauma often contributes significantly to suicidal thoughts and violent behavior, making trauma-informed care essential. Effective clinical practice includes the comprehensive assessment, collaborative safety planning, crisis intervention, the use of evidence-based trauma treatments, and coordination with community resources. As future counselors, our role extends beyond crisis response. We also promote prevention, resilience, recovery, and hope. The information presented today is based on current recommendations from the Centers for Disease Control and Prevention, the National Institute of Mental Health, the Substance Abuse and Mental Health Services Administration, the American Counseling Association, the American Psychiatric Association, and evidence-based research on suicide prevention and trauma-informed care. I thank you very much for your attention through this presentation.